pregnancy. When you think about it, it usually means that there's something jeopardizing the mother's health, perhaps, and also the baby's health, or something jeopardizing the baby's health that may not have to do with the mother's health. So it could be anything that can cause morbidity or mortality to the mother, baby, or both. These are conditions. The occurrence is 1 in 4 pregnancies. It seems to be a little bit high, but again, it depends on the population you're working with. Okay, so some people do not go for prenatal care, so they're more at risk because they're not getting screened for high risk problems. Okay. So higher risk equals higher morbidity, mortality. What's important is early and ongoing prenatal visits. And again, the reason for that is they can pick up different problems and hopefully work with you or work, what's going on with you with the baby, the fetus. Okay. All right, so some of the complications we're going to talk about to begin with is bleeding in early pregnancy, ectopic pregnancy, incompetent cervix, and then as we go along, we're going to talk about preterm premature rupture of membranes, something called placenta previa, placenta eruption, preterm labor, and gestational hypertension and preeclampsia. Okay. Yeah. Yes. Yeah. There's a form usually. I have my master's degree is I'm a perinatal clinical specialist. So what that means is my focus on my master's background was on high risk pregnancy. That was my focus. So perinatal or antepartum are usually people that have high risk problems. Depending, I know Hackensack and I'm in Florida. At Valley, they are on the Bourbon Wing or some other. It's not the same floor, but it's on the other side. You have to get your way through that. And these are people who might be in preterm labor with twins or triplets, or somebody who has a placental problem that they're not allowed to get out of bed, or diabetes is uncontrolled. So they do have certain problems that kind of can jeopardize the baby or the mother. We usually spend a day, try to rotate people in, for a day, at least half a day, to go into that area, just to see. I don't like to do it early on because half the time if I push somebody in there, no one knows what, preeclampsia is, what abruption is and all that kind of stuff. So after we start doing these lectures, I'll be putting my students, like a half day there and someplace else. But I know how Jasper has this. I think she has to actually be there, right? Yeah. Okay, so early, bleeding in early pregnancy. Okay, so a pregnancy that is bleeding, if it's 20 weeks or earlier, they refer to it as an abortion, meaning a miscarriage, okay? Or you'll see on our sheets, our prenatal sheets, we have it as induced abortion, IAB, and then they have it as SAB. So you'll see this spontaneous abortion or IAB, meaning induced abortion. Okay. So anyway, so if it's before 20 weeks gestation, that is considered a miscarriage or an abortion. After that, it's considered a fetal demise. Okay. The loss of the fetus due to natural causes is about 80% of all spontaneous abortions that occur in the first trimester. So a lot of times, the woman may not even know she's pregnant yet, may think she's having a heavy period, instead she might be miscarrying. So sometimes a lot of that occurs without really the knowledge of the woman sometimes. Okay. Bleeding in early pregnancy, the pathophysiology of it. In the first trimester, the causes are varied and unknown. It could usually be something that's genetic. So something maybe is wrong with the amount of chromosomes that the baby has that is not going to be, be able to work with life. They will not be able to live with the type of chromosomes that they might have. Okay. And for the most part, it's usually unknown why a person miscarriages. In the second trimester, causes are from something called incompetent cervix, or in your book will say insufficient cervix, okay? Insufficient cervix is the same thing as incontinent. They didn't want the woman to feel like she was incontinent, so they decided to call it insufficient cervix. And we'll talk about that in a little bit. Any kind of anomalies of the uterus can cause miscarriage in the second trimester, diabetes, drug use, maternal infection, and some maternal diseases in the second trimester. You will see before that. Okay, now let me see if I took that. But this is what one of the reasons why I took this slide over these slides. This comes from the textbook. Okay, this is from the textbook. Both textbooks do have a table like this in it, the new and the old one. Okay, and the reason why I decided to use this is that it's just easier to see. Okay, the threatened abortion. Okay, so these are some of the things you have to know. The difference between the different types of abortions. Okay. The threatened abortion is vaginal bleeding. Often it's slight and it's early in the pregnancy. The big thing with threatened is that there are no cervical changes. The cervix is not changing, it's not dilating, it's not effacing. Okay, there's mild cramping, closed cervical os, again, she's not dilating. Okay, and there's no passage of fetal tissue. Okay, so the fetus is still inside of her, and even the sac is still inside of her. Vaginal ultrasound will diagnose it, confirm if the sac is empty, or if there's a fetal heartbeat, they can see. Okay. There's also different blood tests that are done for a woman to see if she's pregnant. The HCG, human chorionic gonadotropin test. That's the one you see over the counter. That's the one they test to see that hormone if you are pregnant. Okay, so another thing that happens is if you are pregnant, that HCG will double in amounts, for the first few weeks of pregnancy. So they have like a scale where if she's 4 weeks pregnant, the HCG should be this level. If she's 6 weeks pregnant, so they have the different levels that are within a normal range. So what they'll do is they'll do an HCG test and a progesterone test. Serum blood test on the woman to see if the levels are normal or if they're declining. Okay. Management is conservative support, treatment, possible reduction in activity in conjunction with nutritious diet and adequate hydration. So a threatened abortion, what that really means is that it's threatening, but it may not happen. Okay. Because there's no real proof that resting and decreasing activities will stop the abortion, they feel as though women need to feel like they're doing something. So they'll tell them just to rest and take it easy. Studies have never shown resting and taking it easy makes any difference. But I think the woman needs to feel like she's doing something for, hold on to the pregnancy. The next type is called inevitable, okay, inevitable abortion. Now the difference between this and threatened is there's more vaginal bleeding. There's more bleeding, there's more cramping. The membranes are ruptured. There's cervical dilation. Okay, so you can see that in the threatened one, right? This is kind of making you remember what's the difference now. Okay. There's strong cramping, and there's possible passage of product of conception, meaning the embryo and perhaps the little sac that is surrounded by. Okay. The best way to pick this up is ultrasound again. They would do transvaginal ultrasound because it's early in the pregnancy, and they'll be able to see if they can locate a sac, or if they see a fetal heart beating, or if they see an empty uterus. Okay, that the pieces of remains of the tribes of conception. Again, they'll do the HCG levels also. And what they will do to work with this condition is they will vacuum out or scrape the uterine lining of the fetus and the sac. Okay, so this will, what happens if something's stuck inside the sac or stuck inside the uterus starts to contract to try to get rid of it because it's a foreign thing now. Okay, and it makes the woman bleed and have even more cramps. So what they go in is they go in and they strip whatever is left in there to get it out so that the woman doesn't hemorrhage. Okay. So they will vacuum curettage, which is like scraping. Products of conception are not passed to reduce the risk of excess bleeding and infections. This is what they'll do. Other things they might do is a prostaglandin. They might give that to the person. And what happens with that, it also will just help to empty the uterus out. Okay? And that's another thing. And this is only used if they see that the fragments that are left, there's something left behind. If it's all cleared out, they may not do any of this. They may not need to help get rid of anything in the uterus, which doesn't have anything left. Okay? Okay. So then the next type is called an incomplete abortion. Okay? Okay. So the person passes some of the products of conception, like maybe they'll pass the sac, or maybe they'll pass the embryo. Okay. But it's incomplete because not everything is passed. The person will have intense abdominal cramping again because something's left in her uterus. Anytime that happens, you'll cramp. You know, your uterus is trying to get rid of whatever is in there. Okay. Heavy bleeding, and there's also cervical dilation. So you can see how the ones we spoke about, only the threatened abortion at this point has no cervical dilation. Okay. Again, the ultrasound confirmed this. We want the client to be stabilized because again, she was hemorrhage, which is her uterus is trying to get rid of what's ever remaining there, and then they will evacuate the uterus either by dilation and curettage, which is a DNC. So what they do is they dilate the cervix to get in there, and they'll scrape the cervix of whatever is left inside. So DNC is dilating the cervix, and the curettage is sort of scraping out whatever is left. Okay. Also, they can give that prostaglandin. Okay, the complete abortion. Okay, complete abortion is the passage of all the products of conception. So everything. So complete means everything's out. Incomplete means something's left in. Okay, so complete abortion. Usually everything is passed out. They confirm that by an ultrasound, and they don't see anything. The history of vaginal bleeding and abdominal pain, passes of tissue with subsequent decrease in pain. So once the tissue is passed, the uterus feels as though it's cleaned out and it doesn't have to keep contracting. Okay. And then also a significant decrease in vaginal bleeding. As I said, the ultrasound will show that there's an empty uterus. No medical or surgical intervention is necessary because everything's passed out of her. But she will need to have a follow-up appointment to discuss family planning. Okay. Missed abortion. Missed abortion is sad because the woman has all this is sad, but the woman has all the signs of pregnancy. Okay, so she's pregnant. She feels nauseous. She feels tired. Her breast might get a little large and tender. So she has all these signs that she's pregnant. Okay, so then all of a sudden, she goes maybe for her 8-week appointment. They see the little heart. They confirm she's pregnant. And then she goes back 4 weeks later, at 12 weeks, and she says, I don't feel pregnant anymore. My breasts aren't tender. I'm not nauseous. I'm not as tired. I'm just not, feel like I'm not pregnant. And a lot of times the reason is because the fetus died in utero. Okay, it died inside her uterus, but nothing was ever passed. So it becomes mummified in her uterus, the fetus. Okay, so the missed abortion is a non-viable embryo retained in the uterus for at least 6 weeks. Absence of uterine contraction, irregular spotting, possible progression to prenatal abortion. So there is a possibility that maybe the body will eventually abort this, but again, if they pick up this fact that they see a heartbeat, then they will do a DNC on her again. Yeah.
Does that go for the entire term?
No.
Outside of usual discretion?
No, because she goes back every 4 weeks. If the uterus is not growing, the condoms are not getting higher up, and that was something wrong.
But is it possible to get it throughout any point of the pregnancy?
That your fetus dies, and you know, yeah.
And it would be called twisted abortion.
No, if it's after 20 weeks, it's a fetal demise.
That's what-
Okay, if it's before 20 weeks, it's an abortion, and after 20 weeks, it's a fetal demise. But usually after 20 weeks, you feel kicking, and all, 20 weeks or so you feel kicking, and all of a sudden you don't feel the kicking, and you're just not going up, and that would be a bad sign. Okay. So anyway, so the ultrasound will identify the product of conception, what they can see. What they'll do is evacuate the uterus. If an inevitable abortion does not occur, in other words, the body does not, get the baby, the fetus to come out on its own, they will go and do a D&C, okay? And they'll dilate and evacuate they do D&E, which is dilate and evacuate, and usually it's around the second trimester this occurs, okay? They can also give the prostaglandin suppository to help the uterus contract to get her to pass the and habitual abortion. This is a person who has a history of three or more miscarriages. Okay. And again, they just have to look and see what's going on with the woman. Maybe she doesn't have enough progesterone. There's a whole bunch of different tests they do to see why she's not able to carry the pregnancy beyond maybe the first semester of the pregnancy. So she has a history of 3 or more spontaneous abortions, not carrying the pregnancy to viability or term. It's a validation. How you find out is you ask her history, and we'll get that information. Identification and treatment of underlying causes, could be chromosomal, it could be reproductive tract problems, it could be diseases, it could be, hormones, it could be anything like that. Okay. And then some people don't carry their pregnancy beyond the first trimester, and that is because the person has an incompetent or insignificant cervix. Okay, so the person has to have a D&C or D&E, dilation, curettage, dilation, and evacuation. You want to reassure the patient that spontaneous abortion is a result of an abnormality. Usually we don't know why. Nothing she did. And referral to a support group is very beneficial. People are very upset, and there's a loss of hopes and dreams of becoming a family. So this is not something where you say, oh, you're young, you can try again. This is a real loss. It's a very significant loss because of the fact that maybe you've been trying for a while, or, even if you weren't trying for a while, you might just get pregnant, you're just so thrilled. And you start to, vivid imagination of what the baby's going to look like and all this stuff, and then you miscarry. So it is a major loss. And then we have ectopic pregnancy. Okay, ectopic pregnancy. You can see. Okay, so ectopic pregnancy. If you take a look at that picture there, you can see that. Okay, this is the uterus. This is the fundus, the uterus, right here in the body. And this is the fallopian tube, right? Fertilization takes place right there. That's the ovary right there. Okay. And ectopic pregnancy, majority of ectopic pregnancies take place in this area of the fallopian tube. Okay. Maybe there's scar tissue that doesn't allow the fetus the embryo to move past where it is. Sometimes people have scar tissue, and it has no choice but to try to develop right here. Okay. So, the definition is a fertilized ovum implanted outside of the uterus. It occurs 1 in every 100 pregnancies. Can be life-threatening, especially if it ruptures and hemorrhages. A woman can bleed to death and go hypothermic shock and all that. Okay. The pathophysiology, once again, is showing here. Let me just show you some of the places that that could possibly occur in the cervix, believe it or not, okay? Area right when the fallopian tubes come into the uterus, okay? So it's interstitial. This is part of the fallopian tubes. This is also, so look at, most of it occurs in the ampullary area. And actually, this is usually around, well, right around here is where sort of fertilization takes place. So that's the most common area. I mean, you hear stories about it in the stomach or outside the uterus somehow, you know. But this is the area most likely to see is right here by the fallopian tube. Probably some kind of scar tissue or something in the way. Okay. Obstruction, scarring of the tube, pelvic inflammatory disease, gonorrhea, and chlamydia are also possible reasons why a person can get ectopic pregnancy. So again, the chlamydia and the gonorrhea, either one, can cause infection and scarring. So it affects the tissue, it can affect the uterus. So what happens with that is that scarring will not allow for the embryo to get to where it should be. Here. Okay? So those are some of the reasons for that. Okay, management. Okay, the goal is preventing maternal death, promoting rapid recovery and fertility preservation. They can do non-surgical therapy if the tube is still intact. Okay. Shown here, you can't really see it that well though. This is the uterus here, this is the fallopian tube, and this is the ectopic. It's a pregnancy here. All right, so what they can do, there's a couple things they can do. They can do non-surgical therapy on the patient if the mass is less than 4 centimeters. Okay, so they can give the person methotrexate. It's one of the medications they can use. They can also do the prostaglandin, and they can also do the misoprostol as medications to actually, what happens with that, it preserves the tube, but what happens is the growing embryo, it will not allow it to grow. In fact, it will probably make it disappear. That's what, particularly you'll see that with the methotrexate. So methotrexate is used for cancers, okay? It's an oncology medication, chemotherapy medication. So what that does is methotrexate goes right after the most aggressive growing cells in the body. And at this point, most largest, quickest cell growing in the body is the fetus or the embryo. So it will go right after it and attack it and destroy it. Okay. And again, that saves the tube, the fallopian tube. And at the same time, they tell you the woman should not take folic acid when they're giving her this medication because it acts to fights against the medication. So folic acid should not be given. The woman should stop taking the prenatal vitamins when she is on the methotrexate, okay? Because it has this folic acid will fight what happens with the methotrexate. Okay, so the benefit of that is the preservation of the tube. Okay? So if it's greater than 4 cms, or if the tube ruptures, okay? So what happens is, this little embryo is growing and growing, and the more it stretches the tube, the more pain the woman feels. Because it's painful to have that fallopian tube being stretched. Okay, so what will happen is if she needs surgical repair, what they'll do is they'll go in and do a laparotomy. So they'll have like a go into maybe around her belly button area and look to see where exactly they locate the ectopic pregnancy. And sometimes if the fallopian tube ruptures, okay, which is really an emergency situation, because the woman she'll bleed real heavily and she can go into hypothermia shock and die. Okay. So if it ruptures, it's an emergency situation. So with that, they'll go in and they'll do a salpingectomy, which means they remove the tube. Okay, and they sew the area up so she doesn't hemorrhage. Okay. Okay, so some of the nursery assessment, the signs start to occur as the fetus is, embryo is growing and growing. So around 7th or 8th week, the woman will say she has abdominal pain, usually on one side, okay? And it may be a sudden sharp pain, but as the tube, starts to get growing, with the growing embryo, it stretches the tube and she gets the pain. Okay, usually as a one-sided pain. If the pain becomes sudden and sharp, that usually means that it's ruptured. Okay, that the fallopian tube is ruptured, sharp, sudden pain. She will have a lot of times, if there's bleeding into the abdomen, after the fallopian tube ruptures, she might have referred shoulder pain. Okay, so what happens is she might say, "Oh my goodness, my right shoulder really hurts." The pain is because of the fact that the bleeding is going into her abdominal cavity. Okay? Just like if a woman has a tubalization, a lot of times it'll fill her up with a little bit of gas just to bring the fallopian tube up a little bit. So after she has that surgery, the gas pain she feels, usually in her stomach, she feels in her shoulders. So it's referred pain. Okay, so not unusual for that. All right, so then what else? She's starting to show signs of shock. She has hypotension, possible hypovolemic shock. Okay, you review her history. Did she have a history of previous ectopic? She's had one, she's at risk for another one. Okay, especially if they kept her tube, if they preserve the tube, she's at risk for scarring. Also, the person has had her tubes tied, right? Because some people have their tubes tied, meaning that they decide they don't want to have any more children. Okay, so occasionally what will happen is the tubes may go back together, and of course there's scar tissue there, and she is at risk for an ectopic because again, it's not going to have a straight line right to the uterus. There's scar tissue there, so she's at risk for ectopic. If she had a history of STIs, particularly gonorrhea and chlamydia, is they cause scarring. PID, which is hepatic inflammatory disease, which also causes scarring. Okay. Any kind of surgery she might have had to her fallopian tubes or pelvic surgery, again, causes scarring. Okay. If she's been on infertility pills, or she's infertile, or she's on medications, again, she may not have gotten pregnant because of this problem. And sometimes the woman uses an IUD, which is an intrauterine device for birth control. That can cause like a slight infection going on in that area, which again can cause scarring. Okay. Increasing age because of the fact that maybe she did have some STIs, maybe, or surgery, and different uterine abnormalities. So what are we going to do? We're going to try to promote her comfort and pain relief. We'll give her some education. Again, she's having non-surgical treatment. We have to talk about her meds that she's taking, the dosage, the side effects. Surgical treatment, monitor her vital signs closely, monitor her bleeding, monitor her pain. Is she showing signs of hypovolemic shock? So anybody here have ideas of the signs of hypovolemic shock or hypovolemic shock? What's that? Increase in heart rate, decrease in blood pressure. What else? Pulling down skin, okay? But you're going to have to know this for the test. You also have to know this for med-surg, too. Because people have surgeries and they go into shock. I had surgery a few years ago. I had just been left on hypovolemic shock. The next day I had surgery. I do my evening course. The next day I had evening surgery. And I go in there and did the surgery, and then I came out and said, "Oh, I can bleed." And my blood pressure was bad as a newborn. Okay, I was only 140 over 80. It was like, I think it was like 80 over 50. And my pulse was like 130. right? And I'm really out of it, and I say, hypovolemia. Like that. And they're looking at me, and then they said, we're gonna have to do blood transfusion. I'm like, oh, negative. I said, well, we'll take your blood. And I think I'm crazy, you know. So they had to bring me back in, so cared up and gave me 2 years of blood after that, and lots of food. But yeah, I remember saying that. So you have to know that. The signs and symptoms.
Can you make it stand up?
That and the other bugaboo was when I had the surgery. I was in
Make it stand
intensive
up.
care afterwards, and like especially
Pissing me off.
one-on-one. And the nurse left, and I'm coming out of it. I'm so thirsty. I'm losing, you know, over blood and all that kind of stuff. So thirsty, and where's the nurse? There's no one here. There's no one here. And where's the hallway? She didn't have it next to me. Oh my God. So that's why if you see me with you in the room, make sure her core light's there. Make sure the core light's there. And she finally, I was like calling her, and then also she appeared. I said, here's my core light. My core's here. You know, I'm like, so now my big thing is definitely hypervitamin shot. You have to know what you're looking at and make sure that core light is always there. Where's Lauren, right?
Hypovolemia.
So anyway, so pain relief, you know, again, for whatever medication she's on. If she had surgical treatment, you really do have to monitor her for all those items. Emotional support, spiritual support, community support, bereavement groups. Again, you know, this is a loss to her, and she wants to verbalize these feelings, particularly if they didn't save the tube. Now she's, you know, her ability to get pregnant is half because she only has one fallopian tube left. Again, they do have in vitro where they can, you know, can't fertilize a uterus, but still it's a loss. And also the fact she had surgery, okay, is a big deal. And let's see, incompetent cervix, also known as insufficiency, cervical insufficiency, okay? And what this is that the cervix starts to dilate prematurely, and the woman doesn't feel any cramping or any pain. When I used to work with the doctors in my after I'm an I especially I work with doctors who did medicine, high-risk pregnancy. I met a number of people with this condition, and what happens is you don't know you have it until you're pregnant. Okay, you don't know until you're pregnant for the most part. Probably some history should be good, but what happens is in the second trimester of pregnancy, the fetus starts to get heavier, okay, and causes the premature dilation of the cervix, okay? But she doesn't feel contraction. The only way we can find out is when she comes in for her examination, okay? And well, a couple of times we were doing an examination on the woman, and the baby's foot's hanging out of her vagina. And she didn't even know that. You know, she felt something funny there, and she came in and said, I just feel something funny. And not totally out, but something there. And the foot was there. The baby's still alive, but the cervix opened up, and she probably ruptured her membranes. She didn't feel any cramping. And a couple of times this has happened with it, the foot's hanging out. Okay. So what they do for this now, and usually it's in the second pregnancy, because you find out in the first pregnancy this is happening. Okay, so you have a weak structure of the cervix. The cervix dilates without contractions. It accounts for 20 to 25% of mid-trimester losses, usually in the second trimester. And here is a picture of an open cervix. Okay, it's a little bit dilated here. Okay. And what they'll do here is a procedure called a cerclage. Okay, a cerclage. So take a look at what the cerclage is. They go in. Okay, here we go with the cervix, open cervix. And they take, you know, they stitch the area, just like, you ever see like a purse that has like a pull string to it, like a little purse, and there's a pull string to it, and around the top of it. That's exactly what they're doing. Okay, so they are taking the cervix and sewing it in this area here with a couple of sutures, so that the cervix doesn't dilate anymore. Okay, so that's a cerclage. They usually, if the person had this circle, she's in her first pregnancy, they probably will start to do this at around 12 weeks on the woman. If they wait till, all the woman's right into her first trimester, they'll do this cerclage procedure. Okay. Incompetent cervix or insufficient cervix, causes unknown, maybe related to cervical hyperplasia, trauma. Sometimes if a woman has had several abortions and she chose to lose the pregnancy, which voluntary, we used to call VIP, voluntary interruption of pregnancy. So if she's had a number of maybe 3 or more abortions, they keep dilating her up, to get the fetus out. So sometimes that was her to have an incontinent cervix. Okay. Trauma, multiple gestation, a shortened cervix. Also, there's a medication that was used throughout the days in the 50s and 60s called DES. I can't remember what it's a long word. And medication they used to give to women who were miscarrying. Okay, and the DES, probably some whatever hormones were in it. They found that the daughters of women who used DES, a couple of things that occurred. The daughters of these mothers who used it actually ended up getting cervical cancer at an early age and also having incontinent cervixes also. And also going into menopause much earlier than normal. So DES is also something, I have to see exactly the dates of it because it might be just a little past, you're not going to see it anymore. But that's one of the reasons. Okay, so management. What do we do? Basically, we will have her on bed rest, Trendelenburg. Everybody know what Trendelenburg is?
Yes.
So that, everybody? That's in fundamentals? Okay, so that usually means her head is down and her feet are up. Again, that's trying to take the pressure off the cervix. So that's the point of that, just simple gravity. Okay. Pelvic rest. Pelvic rest means no intercourse. Okay. Surgical management, they'll do the cervical supply, so they have a purse string stitch. So they stitch that very simply right around the cervix so it does not open prematurely. Okay. Incontinent cervix nursing assessment. Okay, assess the client for a history of premature labor, any kind of cervical trauma, previous second trimester fetal loss. Then that will give you the idea that maybe she lost the fetus because she had this. Okay. Vaginal discharge, pelvic pressure, cervical dilation, and funneling of the cervix. So funneling of the cervix is the cervix sort of turning itself a little bit. So this can be this pelvic pressure the patient tell you, cervical dilation and funneling of the cervix. The doctor or management person who takes care of the person can do cervical intestinal dilation and then funneling of the cervix is they can do that in the ultrasound. And also going okay, and then nursing management, observe procedures for preterm labor. Again, she's had this for that. Some of the signs of that are backaches, increased abdominal discharge, rupture of membrane, uterine contractions. Sometimes diarrhea can occur when a person has preterm labor. Sometimes heaviness in the thighs due to preterm labor. Teach the patient, talk to them about their anxiety, about their well-being. Pre-op teaching about the supply, education for signs of preterm labor, and activity restriction and fetal repair. Should be followed much more closely than every 4 weeks. It might be every week for the first month after the supply. Okay. So you want to take your break now? Take like a 10 minute, 15 minute break.
Oh, cerclage.